called Doctors Roundtable Discussion, but it's really about the patients and patient advocates, because we're going to hopefully be able to inform you, but better, to the best of our ability, answer some of your questions tonight. And we have a great multidisciplinary group of physicians who are going to talk to you. I would say I want to thank the Alliance, obviously, for sponsoring this. This is the second year we've done this. We did this in Chicago last year, and we've done this at various other medical meetings all over the country. But the idea is it's for you. And we don't want to just talk to you. Many of you think or have some familiarity with CCSVI, so we're going to give you a little background straight from the horse's mouth. But then we'll have some period for questioning, certainly, and that's the most fun. So you can text questions, you say on your thing, to this number, or write them on this card, and Sharon and others can collect those, and we'll try and address your questions. We'll then also, you can certainly spontaneously come to a microphone and ask a question, but that's really the meat of the program. But to get started, we're going to give you an overview on CCSVI, and one of my close friends and colleagues, we work together at the University of Virginia, Bulent Arslan, who's now Director of Interventional Radiology at Rush Medical in Chicago, is going to come up and provide you with an overview. And Bulent?
Thank you. It's an honor to be here. And I have to mention, Dr. Dake is the reason that I went to University of Virginia early in my career. He is, CCSVI is not the only field that he is known. He's actually known with a lot of other innovations and brand new treatment procedures over the years, venous therapy, deep vein thrombosis treatment, thoracic and the vascular stent treatment for energy. It is, his accomplishments are the largest in the field of interventional radiology, and I'm just honored to be to have him as a mentor during my career. So it's great to be here. I'll talk to you about my perspective for CCSVI. Interestingly, today at SIR, we were discussing about evidence-based medicine. There was a topic regarding the evidence in certain different controversial procedures. Like there's a lot of them in interventional radiology. There's a lot of things that we do kind of off-label by common sense, etc. And one of the topics they chose was, well, is evidence-based medicine always necessary? And a couple of the speakers made comments, there was actually a research. People were jumping from the planes with parachutes. Do they really need that? It's like, did anybody show that with, randomized controlled trials that it helps? It was just funny to me. I thought I should mention it to you. And there are things that we do. For example, I do arterial work, vascular work, and sometimes you perforate an artery trying to open up a blockage. And no one has done any study, any research to show that if you put a covered stent, that bleeding is going to stop and the patient is not going to die. So do I have to wait for someone to do that research and not use that stent until that's really proven scientifically? Obviously, this is very extreme. I'm not trying to mock anything. There are a lot of things in the gray area, and we need that evidence. And CCSVI, honestly, research can be done, and we highly rely on our neurology colleagues for that to happen, because IRs will not be able to do it themselves. So the goal is to create that collaboration and make this happen, because it's not just what you and I want. In a few years, insurance companies won't pay for it, Medicare won't pay for it without the research. That's kind of a gatekeeping way for the thing. So if you want to do it right, you have to kind of do it right so everyone gets the benefit, not only the really most encouraged people. So quickly about MS, it was described by Dr. Charcot. First time he's the one that linked the symptoms of MS together with the findings that were seen in autopsy. He's the first person that made the diagnosis of MS, to my knowledge. And shortly after that, Dr. von Rindfleisch, it's hard to pronounce for me, actually suggested the vascular theory for MS. I mean, he's the first one that connected the veins, because the plaques, the demyelination, were happening around the venules on the specimens. So it's not something new. It's not something we just came up with this idea and treating. It's been around forever. It's just that there has never been enough research or possibility for research to prove that or disprove that. Dr. Putnam also proposed, he actually did a dog model of venous obstruction study for MS, and at the end of this paper he said the similarity between such lesions and many of those seen in cases of multiple sclerosis in men is so striking that the conclusion appears almost inevitable that the venular obstruction is the essential immediate antecedent to the formation of typical sclerotic plaques. And this is in 1935. So what is CCSVI and what is the association with MS? Chronic cerebrospinal venous insufficiency, basically meaning there's venous flow problems involving the cerebrospinal circulation, and it does have negative effects on the spine and the brain. It is very likely linked to MS. It's not proven yet, but it is seen the blockages in the veins are seen in the vast majority of these patients. There are a lot of ultrasound studies, MRI studies, some of them are forced, some of them are not. It depends on how it is done. I can only talk about from my personal experience. I was skeptical when I started. I was literally pushed by a patient, you know, that almost threatened, like, if you don't do it, I'm going to go to Bulgaria, and do you think that's better for me, kind of approach. And I agreed, okay, I'll do it, but I don't promise you anything. If you have really something tight blockage, we'll do it, and then we'll see what happens. And that's how I started, and then there was kind of dramatic improvements in a couple of my patients initially, which made me to do more of these, and I have done about 250 cases so far, which amazes me that the degree of venous blockages that I'm going to show some of them could not be coincidental. I mean, how can you have every patient, almost every patient except a few, have significant blockages and you can say that there's no linkage between them? So there is a linkage, but we're at the very early stage. We just have to find out to what extent that affects patients, which patients are affected more, and which patients will hopefully find out benefit from the procedure, so you can actually concentrate on the ones that are going to have more benefit. So venous insufficiency in general, does it exist? Oh yeah, there's no question about that. It's been proven, legs, renals, pelvis, upper extremities. It's very well known, it's been treated forever. Has any of these been confirmed with a trial? Not really. There's no trial that confirmed that lower extremity or upper extremity venous deficiency causing certain problems and treating them will actually provide benefit to the patients. But we commonly perform these procedures because luckily they happened 20, 30 years ago when evidence-based medicine wasn't so emphasized. So it's become a routine, patients are benefiting. We are doing a trial for deep venous thrombosis in the lower extremities after 20 years of practicing it just these days. So, and I'm just afraid that we will be doing a trial for CCSVI 20 years from now, which would be disastrous, you know, because it's a time loss for a lot of patients. So I think it would be best if we just get together, collaborate, and do a trial, prove it right or wrong. You know, just have an answer as soon as possible. And so, for example, I'll show you a couple of other venous disorders just to familiarize you. This is a patient with DVT in the vena cava, and we go in usually in these patients from the leg veins. There's clot inside the veins all the way up. This is the knee area, popliteal. We give some special drugs and use the thrombectomy device that removes the clot. So in this patient, it's all opened up. All that clot is removed. After removing the clot, there was a narrowing right here, which is a common area. Some of you may have heard it, May-Turner syndrome, which resulted all this. So it was a stenosis that resulted the outcome. So that usually doesn't open up unless you put a stent. So a stent was placed. And this is the IBUS picture before. This really high density area is clot. And afterwards, opening, there's no clot, but it's still narrow, so it's likely to clot again. And when a stent is placed, the flow is better. And these patients do pretty well. And this was before and after the procedure for this patient. These patients usually cannot walk, they have pain and swelling. And after the procedure, they return back to normal life. So, another patient, this one is a neck distension. You know, the central veins, these are subclavian veins, brachiocephalic veins, and SVC, superior vena cava is occluded. Treated, And this was done like almost 10, 15 years ago. That's the base patient. And great, gone. Another pelvic problem, congestion syndrome. So these patients also has been accepted by the OBGYN society as one of the main causes of pelvic pain. So they do not even question that it exists, but we never had a trial for it, for management or anything. And so this is just a quick overview of the pelvic congestion syndrome. The part that's important is the nutcracker syndrome, which is compression of the renal vein by the superior mesenteric artery, which kind of diminishes the flow. It's a venous obstruction again, similar phenomena. As you can see right here, this is an aorta, this is the superior mesenteric artery, the vein is compressed in between. So that results in higher pressure in the pelvis and dilation of the veins, essentially collateral that we see in CCSVI, similar phenomena. And these patients have pain related to these symptoms. So you can go in, place a stent, get rid of that narrowing, and patients do better. So, is it, I mean, like we always kind of, over the years, I've been to a couple of conferences, etc. We're always on the defending front of this. Is it at all possible that we may have venous insufficiency in the cerebrospinal system? Just because we have it everywhere else. I mean, how can you claim that you cannot have it above the neck? Because any other vascular disorder, arterial disorder, we have it in the legs, visceral arteries, kidneys, mesenteric arteries, arms, heart, and the neck and the brain, naturally. So, venous disease, we have it everywhere, but not in the neck or the head. It just doesn't sound logical to me. It's just that the matter is we have very little research on it. We haven't investigated enough. It just needs to be investigated, and the road needs to be opened up for this. I'll just go on with a couple of quick cases, what made me a believer. Looking at these cases, even if I see a trial, I'm going to have a hard time. Let's say that these patients do not benefit from it. I personally will have a very hard time because I'm really on the other side of the spectrum right now. But this was a patient, 44-year-old, with fullness and pressure in the head, and he really could not lay down for more than 30 minutes. He and his wife could not sleep. They never had a good night's sleep. Every hour or so, less than an hour actually, according to him, he had to get up. And he had MS diagnosis. His symptoms are not typical. It's actually a very unusual presentation. But his MS was diagnosed with MRI plaques. And he had a Doppler ultrasound that showed flow problems. And with the Venogram, it's very, and this is a severe stenosis. A 44-year-old with no other medical problems, this level of stenosis, granted that we don't know what normal is, other than these MS patients that we do one side there's a blockage, the other side there isn't, blood flows really well. So our kind of normal is as we see on the same group of patients again. But this is a little not normal. If we see this in any other vascular territory, we would just go ahead and treat it. And same thing, this patient treated, now it looks like this. It's significantly different. And this is the same patient, the other side. Again, very tight narrowing. Balloon, improved flow. So, which one do you think is more like normal? I'm just asking the audience without any, you don't have to be a physician or anything. One is veins coming down, narrowing down here. The other was, you know, pretty much flowing all the way down. This is what we're supposed to be. So, and that's what we did on that patient, and he was able to lay flat throughout the procedure, right after the procedure for 4 hours without any problems. It was for the first time for the last 3 years or so that he actually could lay flat. And then he had a great time for up to 10 months without any problems in sleep, not having to get up. We had to retreat him because he had a restenosis at that time. And funny though, when his symptoms came back, we repeated the Venogram, and yet his stenosis came back. And we retreated him, stenosis went away, and since the second procedure, we didn't have to treat him again. He's been doing fine. So this is another patient. I'm just going to like quickly do that for the sake of time, because this has to be more of a discussion pattern. But this is another patient which you can see, not a normal venous flow. And on the other side, this is her good side. This is all the flow that she has. And we treated that. She had dramatic improvements, unbelievable improvements. That I guess there's no limit to what placebo can explain. The symptoms that improved, as a physician, I'm having a hard time. What is the limit of placebo? What can it provide? What can it not provide? This lady had not walked for about 3 years. She was able to move with a walker for very slowly. And after the procedure, she sent me her video. She was literally jumping without any support. And I was worried when I saw the video, yet about within a month she sprained her ankle. Just like, but having said that, she was an extreme. She was one of the patients that had the most benefit. This doesn't apply to every patient. I had quite a few patients who had no benefits. Fortunately, I did not have a patient who worsened other than 1, maybe 2 out of 250 patients, symptomatically. And so now her neurologist routinely refers patients to me. I am one of the lucky ones. This doesn't apply to a lot of people. I had a very good collaboration with 2, actually 3 neurologists within our area. When I started doing this, some patients came without a neurologist. I would strongly encourage them and give them these names that are around me. You know, I'm an interventional radiologist, so I'll treat your vein, but you need to have a neurologist follow you to assess the results, to see if you're really benefiting it or not. That's really important. So I think that paid back a little bit. And when the neurologists that I worked with saw some of these patients, they become more open-minded, and then they started sending patients that they had no options for. And some of them got benefit, etc. So we established a relationship that was mutually beneficial, as well as for the patients. So this is another really interesting patient. He was 34-year-old male, primary progressive, 14-year-old son and wife responsible for taking care of him and supporting the family. He was the worst patient that I treated. He came in on a wheelchair. He had contractures of his legs. I truly regret that I did not videotape him when he came for an initial consult. It's something that everyone should have seen before and after. It was contractures in the arms, legs, etc. And he was, vision was 20/200, legally blind. He could not see anything. He could not talk. He would make very slur speech that I could not understand. His wife would translate for me some of the things. And he was choking, so he could not eat. And I guess they didn't have a feeding tube, etc. The family had very limited resources. And he was down to 90 pounds. He was totally wasted in a wheelchair, literally not living, essentially. And I was really concerned about doing a procedure on him. He was actually my 5th patient. But in addition to all that, he would scream every day several times due to severe headaches. Even though he couldn't talk, he would just scream. And it was frustrating. The wife was depressed, the kid was depressed. It was a very hard situation. So we did a venogram on him. We had to go from the left because we could not straighten his right leg. And the left side, I mean, I did angioplasty this. It's very hypoplastic, athletic vein that did not look any better afterwards, not much change. If it was today, I would not even touch a vein like this. You're not going to get much improvement. And but on the right side, which is the main drainage side, he had a total occlusion. And we measured the gradients. I used to measure gradients on everybody. He had an 18mm gradient on the right side between the jugular vein and the brachiocephalic vein. So I tried to angioplasty it several times. I tried to use the angioplasty primarily if it works. I did not get a good result. It's just very minimal improvement, which I did not feel like it was going to stay open. So when I had stented, it was the first patient that I stented. And after stenting, the flow improved significantly, very little collaterals left. And I thought, I set him up for follow-up. He started saying that he can see better immediately after the procedure on the recovery area, which, I mean, I did not know, I could not prove, so that was the only thing. And I set up for a follow-up in 1 month. He did not show up. I said, okay, you know, didn't help. I wasn't really expecting much. And this is a diagnosis to be Bulent as well. So 2 months later, his wife brought him. He gained 15 pounds in 2 months. He was able to move his arms and hands. And he was able to eat himself from being completely contractured. And he was able to speak clearly. And I have an accent. Between the two of our conversation, he was speaking better than I was. So, and no choking episodes since the procedure, not a single episode of headache. His procedure is from now, almost 19 months. He had a recurrent stenosis at one point, and which we went ahead and treated that right above the stent, which was diagnosed by Doppler. The reason we did this Doppler was because some of his symptoms were coming back. His slurred speech was coming back. He was having weaknesses in upper extremities again. We said, let's evaluate, but it's kind of funny that how he knew that some symptoms were coming back, and when we went back and checked it, yet there was a stenosis again. And after that, this is the Venogram, almost completely occlusive. You see these switched collaterals and everything. We tried to balloon it. It did not get much better, and we stented it. All the collaterals are gone. There's none. Excellent flow, and he starts feeling better again immediately after. So it's, I guess, all just a coincidence, or you know. But for that family, there's no question. They're probably more true believer than I am. So this last case, I'm going to skip it quickly because just to show you that there may be problems. There's a complication rate as with any other procedure. This was a young patient, 44-year-old. He had relatively milder symptoms, but he was not happy with the way he was living. So we had a stenosis, which we angioplasty on the left side. Got a good result. On the right side, a larger vein, good result. And his symptoms improved. He started doing better. He started regularly exercising, which he couldn't before. And but 2 days after the procedure, his doctor showed that there was a clot on the left side, the smaller side. So I put him on blood thinners and said, let's wait and see if it resolves. We waited for about a month. It did not go away. On a young 44-year-old patient, I did not want to lose that vein. I mean, it's like if what we're claiming that the venous drainage is important, you know, losing one good vein is not acceptable. So we went ahead and catheterized that vein and placed an infusion catheter. We have tools that we can break up the clot and get rid of it. And we did that, and angioplasty, and he's on long-term anticoagulation, which has stopped right now. He did good. This is his follow-up ultrasound. There's very little residual in the wall, but overall very good flow. So there may be complications. You need to be dealing with people who can take care of those complications when necessary, and be aware of it, sort of weigh the risk benefits, and just like anything else in the world. So where are we right now today? I know where I am, but I do not matter. So what's important is the insurance companies, Medicare, hospitals, neurologists. So we need to get everybody else on board. And I talked about that evidence-based medicine. Without evidence, it's not going to go anywhere. It's just going to stop. It's actually going to get worse. Even the patients who had the chance to have the procedure will not have the same opportunity down the road in a few years. So we have to get together, collaborate, and do a trial that is reasonable and that will help us to understand if, first thing, if this procedure helps our patients or not. And once this resolved, there's a lot more to answer in this field. And hopefully once the door opens up, we will get there.